Okay, and just so everyone knows, we are recording so that we can share this out with the rest of our organization for folks that can't make it live today. But thank you all for making time. This is our third training under the Planting the Seed series, and we're excited to keep bringing new topics. And just kind of as a reminder, we're doing this series really around topics that really kind of support us in providing quality care to our patients. In particular, that really helps us to meet our diverse patient population where they are and what their life experiences are, and really kind of provides quality of care that meets their needs and hopefully really helps them to have a positive experience and positive health outcomes as a result of that. So today we'll be talking about sort of weight and supporting people around their kind of journey around managing, a healthy body and also eating disorders. And then from this, we'll have a follow-up discussion in October, on October 26th. So that today is really kind of Kate and Hillary are going to share some information with us, and hopefully there'll be a little bit of time for questions as well. But really also having a chance to debrief and dig into kind of what you want to implement from what you learned today on October 26th. So that's kind of how we're still doing the setup. And then in November, we're really excited that we're going to have the Pride Center come and provide a training presentation. That one's actually going to be 2 hours long on providing affirming care for LGBTQ patients. And we're really excited to have them come. It's a real honor to have them as a resource to share with our organizations. So I think without further ado, I'll turn it over. Oh, yes, Dr. Valinsky, you have something you want to say?
We're going to block some people out for the LGBTQ.
I can't really hear you.
Oh.
Nope, that's better. Yep, that's better.
Are we going to block some providers out for the LGBTQ thing so that we can get a wider audience?
I believe that has already been done, but I will double check.
Fantastic.
Yep, I think we sent an email saying we had your approval to block that time. So hopefully it was done, but I will follow up and make sure. Yep, we've been blocking times for each of these. Great. So Kate and Hillary, I will turn it over to you. We're so lucky to have such amazing resources within our own organizations, and Kate and Hillary are going to share their knowledge with us today. Thank you both.
All right, thanks, Hannah. So I'm going to start. I'm Kate. You guys know me here. I'm the dietitian, diabetes educator, and care coordinator for CHT here in Stowe. And Hillary is going to follow up afterwards. And I am going to start us off kind of talking about weight concerns and weight stigma. And I'm just going to kind of jump into it. I'm going to go fast through some of the things, but just know if you kind of have some things or what we want to talk about, that we'll have that whole other time to kind of discuss things. So, just a little bit about my background. So I've been a dietitian for like 14 years, and I'd say the first 10 of it, I think a lot of us as healthcare providers are taught a lot about the obesity epidemic and weight management. And I think through doing that in a lot of different ways, outpatients and online behavior management, all the different ways, kind of seeing some patterns of weight cycling and things that we're going to talk about today, and really kind of questioning, why is it hard for people to lose weight? Why does it keep coming back? And so that's when I really did a deeper dive into the literature. And that's what I kind of want to share today. And just sort of found this different way of thinking was just really meaningful for patients and kind of rewarding for my own personal practice. So that's kind of what I want to share today. So my objectives are to compare what we call a weight-centric paradigm to weight-neutral paradigm, to understand how weight stigma impacts health, and to discuss how to address weight concerns. The literature kind of outlines at 4 different weight-based paradigms. So the first one, a paradigm being the mainstream belief, right? The first 2 are really the ones that we live under right now, which is what we call weight-centric or paradigms. And so that's the idea, like obesity is a problem, and by changing energy expenditure, that will change BMI. So things like calories and portions, if we just watch those things, that'll change everyone's BMI. The second weight-centric paradigm is, oh, okay, well, no. How about we focus on the environment? Now, if we change their environment, that will change, you know, their weight. So if we do like the soda tax or the food desert, you know, trying to see if that impacts obesity. The next two are what we call weight neutral paradigms or weight inclusive paradigms. And they kind of say, well, what if we just optimize the psychological, the physical health, the well-being for all shapes and sizes through things like intuitive eating or pleasurable leisure or physical activity to see if that improves health. And the fourth kind of moves beyond that individual lens to look at more socio-environmental factors that impact health, like social issues, weight bias, stigma, and discrimination. So those are weight neutral paradigms that we're going to talk about today. So this is a paper that looks at the evidence for, you know, whether or not some kind of shift from a weight-centric to a weight-neutral paradigm makes sense, if there's that evidence. And some of the things that paper was talking about, you know, says the current weight-centric paradigm recommends that, you know, overweight and obese individuals engage in this lifestyle modification that involves diet and exercise. This approach reliably induces some short-term weight loss, but for the majority of individuals, they're unable to maintain that long-term. That doesn't always improve their morbidity or mortality. So there's concern that it's not only ineffective, but that it also might have some unintended consequences we're going to talk about. And then this concern kind of draws some attention to ethical implications, like recommending treatment where there isn't necessarily long-term evidence. So this paper also talks about some assumptions of a weight-centric paradigm, and these are just 4 of them that we're going to talk about. But the assumption that adiposity or fatness poses significant morbidity and mortality risk. The assumption that anyone who's determined to lose weight can keep it off if they just try hard enough with appropriate diet and exercise. The assumption that the only way for people who are overweight or obese is to improve their health is by losing weight, and that weight loss pursuit is always, you know, health promoting, doesn't necessarily take away from their health and wellness, and that BMI is a good indicator of health. So we're going to talk about these individually. So that first assumption, adiposity increases morbidity and mortality. So this is just sort of a handful of studies, not expecting that like we're all going to just sort of like shift our whole focus based on this, but just planting the seed today, right? That there sort of is this other literature out there, that there are other things that might explain why someone could be in a larger body and be perfectly healthy. So there's a range of cardiovascular conditions where that obese BMI category has more favorable survival than that healthy weight category. So there's just a couple citations there. A couple studies have found that. Another meta-analysis of 20 studies that showed there's a lower all-cause mortality for people with diabetes in that overweight category compared to the healthy one. Another pretty large study with ischemic stroke in the obese categories had significantly lower vascular events than that healthy weight. This idea that there's some chronic inflammation that's been demonstrated as an important risk factor for the development of type 2 diabetes independent of weight. So as opposed to that common belief that weight, you know, is what causes or precursor to diabetes, that regardless of what their weight was, that there's some other kind of chronic inflammation that's going on there. That there's significantly higher rates of mortality rates in also the very low BMI category. And then just that these behaviors, so fat active people had half the cardiovascular disease than sedentary healthy weight BMI, and that all-cause mortality was improved based on having 4 healthy habits compared to 0, no matter what your BMI was. And I should say, you know, the term fat, when I use that, is something that a lot of people are trying to reclaim, but it might not resonate with everybody. I'll often use obese or overweight when I'm talking to people in quotes, or just use larger bodied. But you'll see this in the presentation, as that's what they use in the literature a lot. We should also just mention that like the weight loss medications also can carry morbidity and mortality risks themselves. So this isn't saying that, you know, all people in larger bodies just are automatically healthy, or that we shouldn't try to be healthy, right? This is just saying that because someone has, you know, fat on their body does not automatically mean that they're unhealthy. This is just a nice little graph that just shows how on these kind of ends of it, right, those are the kind of the highest risks, the very low and very high BMI, but actually the lowest risk of mortality seems to be what we would consider the overweight and obese categories, at the lowest mortality in this case. So I'm going to do a couple of what we call these radical reflections, again, just kind of planting the seed here, something to keep in mind as the presentation goes on. But what if this idea of this obesity epidemic isn't getting worse? What if our current paradigm is making it worse? Do we really feel like what we're doing right now is helping our patients? Do we feel like they're getting more out of it? Do we think it could be taking away? So that second assumption is that weight loss is attainable for the majority of people if they just try hard enough. And so there are quite a few citations in this first one that says there's really no evidence that weight loss efforts are effective in achieving significant sustained weight loss outcomes. There's a failure rate of about 95%. Not only is it difficult to maintain, but it also predicts weight regain. So several studies have shown this. Another one kind of said 1 to 2/3 of dieters may actually gain more weight than what they originally lost. And this is true of children, and the BMI reduction is quite small, of course, because children are still growing. And even studies that have looked at twins, when we compare a dieting twin to a non-dieting twin, the dieting twin actually ends up gaining more weight over time and is actually more likely to develop some disordered behaviors as well. And so this really strikes me because, I think that we can see a lot of this. Like we can look in charts and see that it goes up and down and up and down and up and down, but it goes up maybe over time. And so I kind of ask you, do you feel like you have, like the majority of your patients are able to lose weight and keep it off their entire life? Or do you find that this is a very short-term thing that happens? Do you feel like 95% of people are successful, the majority of people are successful, or do you find the majority of people would fall into, what these studies are showing? And that can be helpful for your patients because, maybe it's not their fault, because often they are believing that to be their own fault. I think diet culture really reinforces, oh, next time I have to try harder, next time I have to do better. Like it was my fault that I gained it back, instead of showing that in, study after study, people are gaining it back, that maybe it's not their fault. Oh, so some more studies. This is from last year. A study asked, is sustainable, stable, long-term weight loss a viable goal for adults with obesity? And the results really showed that, it can be lost, but is really regained over time for the majority of patients. Another study found that no weight loss initiatives to date have found long-term results. At best, maybe 20% maintain that weight loss at 1 year, but that percentage continues to go down after that. So here's another radical reflection. Just because an initial weight loss is possible, are we assuming that it's a personal failure, that we can't keep it off? Are you assuming that everyone you see in a larger body than you is eating more or exercising less than you are? So even if you personally are able to manage your own weight through some kind of healthy behavior, it does not mean that everyone who follows exactly what you do will have those same results. And so this is really the idea of body diversity, that bodies come in different shapes and sizes. It's really, what can we do to support the size we're at right now? So that third assumption said, weight loss promotes health. And so there are some studies that have shown, like, actually 21 long-term random controlled trials found that the weight loss diets had minimal changes in those things like blood pressure, cholesterol, but none of these actually correlated to that weight loss. Another study showed that they did not provide consistent evidence that the dieting resulted in significant health improvements. And in some, there's little support to the idea that diets lead to lasting weight loss or health benefits. There are long-term studies like the diabetes prevention that showed, weight was regained, but some people were able to reduce that risk of diabetes. Even the look ahead trial, that often the research you'll see in the literature, oh, the look ahead trial had all this success. But actually, even with intensive lifestyle intervention, it didn't decrease cardiovascular events. So the study was stopped for futility after 11 years. So not only do these efforts kind of fail to improve health, but there's actually some risks associated with that. So we know the weight gain, the weight cycling, osteoporosis, chronic psychological stress and cortisol production, anxiety about weight, eating disorder behaviors, and stigma. So that last assumption that BMI is a good indicator of health. So I think a lot of us can agree, right? BMI was meant to be the screening tool, not necessarily this diagnostic tool. And there are lots of limitations. It doesn't take into fact, muscle mass or bone density or genders or ethnicities, or just that fundamental idea that bodies come in different shapes and sizes. And so not all bodies are meant to fit, be in this very small parameter. And we can't really expect everybody to change. And so this kind of brings me to this idea of health equity. And I like this image because we can't expect that if everyone follows, 1200 calorie MyFitnessPal, they're all going to have the same weight or the same blood pressure or whatever, that different bodies are going to need different support. So fun facts about BMI, invented by an 1830s mathematician, also white male. Women during that time were shorter, not encouraged to work out, nor would that be like a thing. Even, Black bodies during that time were considered inferior to white European bodies. They were considered not being able to control their oral or sexual appetites. You will still hear this echoed in, modern times, even though Black bodies are healthier at higher weights than white women. So there's just always been this idea of, there will always be diverse bodies. And the question is really, how can we respect body diversity and find what works for them? So that brings us to the question, is obesity a disease? And we know as of 2013, the American Medical Association had voted to make obesity a disease. Oh, they did make it a disease, but actually the special committee had actually recommended we not make it a disease because of the literature about weight stigma. The membership then voted and they all decided to make it a disease. And it's worth noting that at least some people are going to benefit financially from that being billable code. So what is weight stigma? So weight stigma is that negative belief or attitude about a person's weight, such as believing that a person in a higher weight is lazy or sloppy or non-compliant. And even if you don't believe those things to be true, it might even just be assuming they must not be eating well, they must not be exercising, they must not have good health. And so weight stigma can impact a person on a personal level, how they seek or receive medical care, how they interact with society. But it could also be something that they held to themselves, like bias for just themselves. So this is known as internalized weight dissatisfaction in the literature. And so it might not be those overt kind of things like a rude comment that someone said. And I don't think that happens here, but it could be just something like assuming someone's not exercising when they could be exercising every day. It could be things like, well, you just have to watch what you're eating when they're already eating very little. Confirming, congratulating someone for losing weight when maybe they were sick or starving themselves. So here's some of the weight stigma research. And I personally found this really interesting because I had no idea that it existed. It's not super mainstream, but just the perceived weight discrimination can double the tenure, what they call high allostatic load or negative impact that can accelerate a disease. Just the desire to lose weight was more predictive of unhealthy days than BMI. Experiences or expectation of poor treatment can cause avoidance in care or mistrust for adherence. That higher weight-based internalization predicted greater odds of having things like high triglycerides or metabolic syndrome or even diabetes, regardless of what their BMI actually was. And then the highest level of food insecurity had the highest level of weight stigma, compensatory bulimic, and exercise behaviors. Some of the people who have had bariatric surgery are some of those with really high internalized weight stigma. Even after weight is lost, we know that people still might have reoccurrences in diabetes or things like that, might have more things like fractures. It's estimated about 24% of that weight loss is lean body mass. This is the statistic that really got me. So a meta-analysis of post-bariatric surgery patients found that a higher self-harm and suicide attempt risk than their BMI matched controls, about 4 times the suicide rate. and then 2 times the alcohol use disorder. So just something to consider when we have patients who maybe are at risk for these things. Weight stigma can also overlap with diabetes stigma, that idea that if you just eat right and exercise, then maybe you won't have diabetes, for example. And we had one patient that said, I didn't want to come into the office until I lost 30 pounds and diabetes wasn't my fault. This is a 40-year-old guy, came to us after avoiding care in another state. He thought he had lifestyle managed diabetes, but his A1C that day was 11. We don't even know how long it was 11, right? But again, if you just eat right and exercise, maybe he wouldn't have diabetes. So that's how we kind of get into this and could potentially cause some harm. Even though, so we have these GLP-1 medications that often, they're the pitch behind with these pharmaceutical companies that helps you lose weight. But that's not actually the mechanism of action. And so, there's maybe 0 to 10 pounds that's lost. And maybe the patient's expectation is that it's going to be a greater weight loss, and what they often experience are these GI side effects, and maybe long-term end up stopping these medications. Instead, when we could put the focus off of weight and on something like, this could really help your A1C if it's 11, or it's actually been proven to have these cardioprotective benefits, and talk about how we can minimize some of those side effects. Binge eating is also disproportionately higher in people with diabetes. And one of the most common triggers for binge eating is restriction. But why do people restrict? Because they're trying to lose weight. And so they don't eat, try to eat very little, and then it snaps, and then we binge. Oh no, I binged. Pull it back, restrict. And so they just get caught in this. But if we could actually neutralize the weight, so if they didn't have to restrict, if they didn't have to focus on their weight, they could just focus on how do I help my health, right? Then we could help to neutralize some of that binge behavior. So stigma also can impact people with diabetes and thinner bodies, right? Because maybe those bodies need insulin, but they think, oh, if I just eat healthy and exercise, then maybe I don't need insulin. Insulin's for really people maybe in larger bodies. Is a false assumption there. But it's some of the stigma around weight and diabetes that could potentially harm someone. So this is a quick radical reflection, just thinking about the way that maybe someone's, if they're diagnosed with cancer, is like, oh, how are you feeling? How can I help you? What do you need? When someone's diagnosed with diabetes, this isn't what we're saying, but this is what they're getting out in the world with friends and family, is like, guess you did this to yourself. Guess you shouldn't eat bread, right? And is this working? Like, this is not helping anyone. Instead you could say, how can I help you? Or no matter how much weight you lose, you're not going to lose your genetics, but we can kind of manage this, how can we help you? I don't have time to go into poodle science today, but some bonus points if you want to look up poodle science, a very short video on YouTube, it's like 2 minutes, could be really great for patients or just us just challenging those assumptions, and more about that idea of body diversity. We can do that next time. So this we're comparing that weight-centric to that weight-neutral model. So we know that weight-centric model is about, aiming for a certain weight. There's good and bad foods, counting calories, for exercising to lose weight. And so that weight-neutral paradigm would say, let's try to find our natural, what we call set point, in response to when we're eating well and moving our body. All foods are acceptable. We want to move our body in ways that we enjoy. Our quantity or quality is determined by internal cues like hunger or fullness. So a weight neutral lens doesn't necessarily mean anti-weight loss. It's just trying to take the emphasis off of weight. It's just trying to put that on the back burner and say, your healthy weight is whatever your weight is when you're taking care of your body to the best of your ability. So what can we do instead? We can just focus on the behaviors, put the weight on the back burner. We can support people in adopting healthy habits just for the sake of them being healthy, right? Rather than for the sake of weight control. We can promote eating in a flexible manner that values internal hunger cues and satiety. We can find joy in moving one's body rather than for compensatory behaviors like trying to change one body. Accepting and respecting the natural diversity of body shapes and sizes. So these, oops. I don't know if someone's trying to say something. These are not necessarily controversial topics. These are what we call a health at every size approach. I know when I first heard health at every size, I was like, that's not possible, right? We've seen people and they're not healthy and they're not happy. But it's really more of a movement in terms of a non-diet approach to focus on habits. And there have been a few studies, 6 random control trials that compare this non-diet approach to a control group. So instead of teaching calories, they're teaching body acceptance and self-worth. They're teaching about internal cues. So instead of saying, oh, maybe I'm not hungry, maybe I'm just bored. Like, we don't judge that of other body signals. Like, maybe I don't have to pee right now, maybe I'm just bored. Like, to really trust their internal cues. And find activities we enjoy, learn about nutrition. So they found that depression and body image improved with those types of interventions. There were improvements in some labs, much less of a dropout rate, more engagement. But weight loss is not necessarily the intention of this. So, but a diet approach, right, would lose the weight and then just gain it back anyway. So our next radical reflection just sort of asks, like, if weight loss doesn't work for the majority of people, because in the long term, they're just going to gain it back. If weight loss is associated with physical health outcomes, poor emotional health outcomes, and there really isn't evidence to support that losing weight long term will improve their health, can't figure out how to maintain that long term, then should we be recommending weight loss? Could it be causing harm? Is this ethical? Is certainly a question to ask. So really the biggest message here is just focusing on behaviors rather than weight, putting that on the back burner. I'm going to skip over this in lots of studies that show we can improve our health by behavior. So we have a lot of patients that are going to come and they're going to say, how can I lose weight, right? I would be so much happier. I would be so much healthier, right? You also have patients that are coming to you and saying, I'm in pain. How can you help me, right? And you're going to base that decision based on evidence, right? You're going to base that decision on not doing them harm, right? So, trying to figure out, weight doesn't dictate our health. What can we do? There's plenty of people with diabetes or heart disease that are also in thin bodies. So, trying to help focus on those behaviors is what we can do to kind of help support them there. And so there are different things that we can say. I kind of outline these as brief or more in depth. So briefly, we can just sort of validate, like, wow, you're really trying hard in this. I can see that you're trying, we can look at their weight history and see that it's cycling up over the years. We can ask, hey, is that helping? How is that working for you? We can help to bust some myths and just say, maybe this isn't helping your health right now, or asking them, what do you enjoy? What kind of movements would you like to do? And, they might not, everyone's going to be able to let go of this idea. I don't expect everyone in this room to even let go of this idea that, that they can't lose weight, but we could still kind of refocus that and say, okay, I hear this is important to you, but let's just focus on those behaviors. The next time I see you, I want to, hear about the walks that you're doing. We can recognize if they're being really hard on themselves, right? Or if they're taking care of others more than they're taking care of themselves. And the more in-depth things, they might be things that like Hillary or myself might focus on, but they could be things that maybe counselors could do a little bit deeper dive. What has been their experience in their body? So a lot of people might have been in a larger body or perceived to be so since they were a kid. And what's that been like for them? What else is important to them besides their weight? So maybe they want energy. Maybe they want to play with their kids. Let's focus on those actionable things. Counselors can really help to recognize some of that cognitive distortion, all of that all or nothing sort of thinking, some of that negative self-talk, and how that might impact their motivation, and exploring things like radical acceptance or body respect, or self-compassion. What not to say would just be kind of assuming that they maybe automatically want to lose weight or they're automatically not eating well or exercising, being careful not to congratulate weight loss without really knowing, because it could have been in an unhealthy way. Being mindful of how complicit we are by affirming or approving something that might not be safe or effective, like, crash diet or a supplement. And, not everyone's going to be happy that like we can't magically turn their body into a different shape or size. But they're also not going to be happy if we promise them this weight loss and, doesn't end up working and they regain it back, that they might not come back to the office. And then just avoiding the terms like overweight and obesity. I remember thinking that was a very clinical term, but I promise you our patients do not. They find it very stigmatizing. So I think the next time we talk, we can talk about kind of challenging our own biases. It's important work and kind of just figuring out like what's stopping us from maybe trying this. Like what would it be like in the next month to just try this out, see what happens, come back, talk about, you know, what our concerns are. And so the last thing I want to do is just play a little case study here for you.
You know what I felt?
And so this is a patient who is doing some kind of, you can hear she has this weight neutral perspective. And she's, when we pick up this video, she had actually spent a month in Florida. When she went down in the airport, she had a hard time. She had to stop a lot of times, take a break. And she'll talk about how when she came back, she didn't have to take those breaks because she had done some more exercise, some water weights she just talks about. She actually doesn't, you know, she shared with me, she doesn't want to see her oncologist because they had this conversation about her weight and, you know, felt like they said, you know, we did our part, now you need to do your part. So anyway, I'm just gonna play a couple of clips and it'll just be another minute or two, so.
Those water weights, used those in the pool, I'd say 3, 4, 5 times a day and had fun with it. Just enjoyed it and didn't think of it as exercise or something I had to do, really just thought of it as fun. And by the time I had to fly back, I was walking across the airport with no problem. So
That's amazing.
it was fantastic. I felt so good. And again, it's the intuitive eating piece, like I said, is that I wouldn't have used that as a measure of anything. I would have thought, oh, you're still way overweight, you're still a failure, you're still not losing weight. It's not, you know, and I would have given up. I would have been like, well, that's not going to make a difference anyway. So why? Because nothing works. So it's changing that mindset to being able to find those things that do work or do have some value and make you feel successful, which is kind of ridiculous. I mean, I know it's just water weights, but say, okay. And the first thing I did when I came home, that scale was sitting right in my bathroom where I'd left it. And I looked at it and I felt this overwhelming urge to get on it. And I didn't. I literally picked it up. I almost chucked it into the driveway, but it's glass. So I was like, don't, you're going to ruin it for yourself. You're going to ruin this happiness because whatever that scale says is whatever it says. Don't take that away from yourself. And I knew I had to get it out of my house because if I didn't, it was going to be there all the time.
Yeah.
You know, and now I walk in the bathroom and it's not sitting there looking at me and it's a nicer experience. You know, if I want a brownie, I have a brownie or I have a bite of a brownie and I taste it and I enjoy it. And then I say, do I need some more of this brownie or am I good? Whereas before I would not eat the brownie and I would eat everything else in the kitchen, you know, and just like trying because I'm so, you know, you're so hungry and then realize and probably half the time eat that brownie at the end anyway and then feel horrendous about my day and feel physically sick because I've eaten too much food. But it wasn't the food that was going to satisfy me, you know? So that doesn't happen for me anymore.
Yeah.
I really don't.
Point of exhaustion because I'm feeling stronger.
I can't fully describe how much dieting and the negative self-image of dieting has been in my life for 30 years. And I would say if you had a pie chart, like 45% of my headspace.
Wow.
Yeah, that's sad, isn't it? But think about life and culture. Everything you do involves food. Everything.
Right.
So if you're trying to cut back or you're feeling shameful about how much you eat or whatever, it's going to impact everything you do. And it did. And it doesn't now. And that's pretty cool.
Yeah. So what are you filling up that 45% with?
Yeah, just life, just enjoying things, just really feeling happy. I mean, I've had happiness again.
Alrighty, so that's it for me, but just planting some seeds here for having a discussion about how we can best support our patients. So I'm gonna hand it over to Hillary and we can discuss more next month. Oops, I think I have to. Sorry.
You know what I can also do?
Oops.
I was going to say I could also write an email and describe it, the situation, if you prefer that.
Oh yeah.
Okay. Thanks, Kate. That was an amazing review of the literature and the situation that we're all facing and dealing with people with weight concerns. I'm Hillary Warner. I'm a dietitian and I'm also a certified eating disorder specialist. The perspective I'm coming from is both as a dietitian as well as someone who developed bulimia when I was 15, which I had until I was 22. And then I struggled a lot with binge eating for a long time after that. I also tend to kind of border on prediabetes, despite being super active and eating well and being thin. And my mom is very thin and also has diabetes, and she eats well and is very active. So interesting tidbits. I think one of the most important things for my presentation that segues from Kate's is that having a weight neutral stance is really, really important for identifying eating disorders, for preventing them, and also for treating them. Because if you come from a weight centric space and you have a patient who's lost a lot of weight, you might congratulate them for that, even though they've only been eating zucchini for the last 2 months. Or you might applaud someone for exercising, even though their exercise is so frequent and extreme that they're getting fractures or other injuries from that. So just a little review on what some of the different eating disorders are, starting with anorexia, which is typically a condition in which there is calorie restriction to the degree that somebody's weight is far lower than is healthy for them. And people who have anorexia can get to that low weight by dieting or restricting or fasting, but they can also get there by through binging and then purging. Bulimia is a diagnosis that's associated with eating large amounts of food, typically much larger than what someone would eat in a similar situation or a similar amount of time. And it's followed by some kind of compensatory behavior. I think we often think of it as being vomiting, but it's not always. It can also be exercise. It can be using diuretics or laxatives, or I don't remember if I said running as well, or bicycling or whatever. And then ARFID, which is the abbreviation for, oh, I skipped binge eating disorder, which is similar behavior to bulimia when someone's eating lots of food in a short amount of time, feeling a huge amount of guilt for it and remorse, but not compensating and getting rid of the calories. ARFID is an abbreviation for avoidant restrictive food intake disorder. That's a newer diagnostic criteria, which is often seen in younger kids, but can also be seen in adults. But in this situation, the person doesn't have any concerns about their weight or their shape, but for some reason, they're not consuming enough calories, which results in poor growth or nutrient deficiencies. Sometimes there's a situation where the person had an eating experience where they choked or they're afraid of pain. So they're not eating enough to meet their calorie needs. And then the last category, the other specified eating disorders, covers things like atypical anorexia. This is another newer term, which refers to people who have all the same characteristics of people with anorexia, but they have a larger body. So they can be just as sick. They can have a significant amount of weight loss, amenorrhea, lab changes, and other signs of malnutrition, but their weight is much larger than considered normal, or they might have a normal weight as well, but they don't have the low weight with regular anorexia nervosa. A purging disorder would be someone who is purging to change their shape, but they're not binging before it. There's night eating syndrome. And then the other one was, so somebody who has restriction and weight loss or binging and purging, but not frequently enough to qualify for the actual diagnoses of anorexia or bulimia. So the reason, or one of the many reasons that treating eating disorders and identifying them is important is because it has so many consequences for the body. Just not getting enough calories. I think the poor maligned calorie, people are so afraid of calories, but they're so wonderful. They give us life and they allow us to love and they allow our bodies to function properly. When we don't consume enough calories, it affects every single system of the body in ways like osteoporosis can't be corrected for someone, a youngster who doesn't reach their peak bone mass. And for people with bulimia, I had a patient who had her teeth were just nubs from her vomiting over the years. The electrolyte disturbances that can happen with bulimia can be life-threatening, and the list goes on and on. So eating disorders don't develop overnight. There's really kind of a process or a continuum. So maybe someone is in a health class, and in the health class, they're being taught about the dangers of sugar. I'm gonna say dangers of sugar. And I've had many teenagers who are terrified of eating an apple because it has too much sugar in it. And they may have some vulnerabilities that we'll talk about in a moment that set them up for that. But that may sort of start something, and then they may sort of dabble in some disordered eating before they develop a full-blown eating disorder. And there are wonderful opportunities for nurses, for therapists, for care coordinators, for primary care providers, all to start watching for signs and symptoms that somebody might be able to get into trouble. Because early identification and getting someone into treatment and stopping behaviors really increases someone's chances of having a full recovery and getting better and preventing the things that can go wrong. So, but one of the big challenges is that it's really impossible to tell who has an eating disorder by looking at them. Eating disorders don't discriminate. They can affect people, patients of all ages, all genders, all socioeconomic backgrounds and ethnicities, and all different body shapes and sizes. So that makes it really tricky. And this slide used to just say it's hard, but I changed it to impossible. But it is helpful to know that there are different factors that can increase someone's chances of developing an eating disorder so that you and parents and communities can have their antenna up. So if everyone in this who's attending this presentation did a little survey in which we asked about your genetics, do you have someone in your family who's had an eating disorder? Do you tend to be perfectionistic? Do you participate in a sport that is really weight focused? Do you tend to be anxious or depressed? Have you had some bullying? So just based on those answers, we can identify people who are more likely to develop an eating disorder. And sometimes some people couldn't develop an eating disorder if they tried. They just don't have the makeup and the things in their environment and in their lives that would lead them toward that. But dovetailing to Kate's presentation, one thing that I often hear from someone is that they decided to start eating better or to eat healthier or to go on a diet. And that vulnerable person loses a little bit of weight and they're down the rabbit hole because in their brain, under eating and losing weight feels really good and it's really exciting. For most people who try to eat, follow some special regimented program, they're like, this is ridiculous. I'm not going to do this anymore. But that vulnerable person is right down the rabbit hole. So the American Academy of Pediatrics says that PCPs are in a unique position to detect the onset of eating disorders at their earliest stages and to stop their progression, be knowledgeable about the risk factors and the early signs and symptoms. And the Academy for Eating Disorders says that parents and guardians are the frontline help seekers for children and adolescents. Trust their concerns. Even a single consultation about a child's eating behavior or weight shape concerns is a strong predictor of the presence or potential development of an eating disorder. So what are things that all of us can be looking for? Nurses, therapists, care coordinators, and primary care providers. You might hear a patient, well, I think a great place to start is a growth chart with younger people. I'm going to show you some growth charts at the end that, that really show some of the changes that sometimes happen before an eating disorder shows up. You might hear that someone's not getting their period. I often hear people complain about their hair isn't as healthy as it used to be. If you're a therapist, you might notice that someone has some red marks on the back of their hand. So if they're making themselves vomit, their incisors might cause a callus or a red mark. So we already talked about the dental problems, maybe some swelling in the neck. GI complaints are very, very common, and they're often, I don't know if red herring is the right word for that metaphor, but oftentimes that's the first way that a youngster or an adult presents, is they're having a lot of GI complaints. And there's all this energy goes into trying to figure out what's causing the GI complaint, when actually eating would make things really operate much better and resolve some of those complaints. So if a parent or a guardian is one of the front lines of noticing things, what might they notice? Well, one of the problems is that some of the things they might notice are really applauded in our culture. So a lot of parents are really thrilled when their child starts to eat more in a more healthy way, or maybe a spouse might be be thrilled that their partner is eating better and is starting to exercise more. And we're like, wow, you have such discipline. You're not having dessert. I'm so impressed. And oh my goodness, you're getting all that exercise in. And that it may be a sort of a pathological thing. So sometimes parents don't pick that up. And parents it's like going to a different planet for them. They have no reason to suspect an eating disorder, and it sort of is happening right before their eyes. But in my experience as an eating disorder specialist, it's like same old, it's the same list. Oh, they're cooking a lot and they're really interested in the grocery list, but they don't want to eat anything that they made. And so it's these lovely people who were also unique and diverse and well-balanced, they all become exactly alike as they move into their eating disorders. I wanted to thank many of you who responded to my quest for things that you wanted to take away from this presentation. And one thing that I heard a lot of is people were looking for different screening tools. The SCOFF questionnaire is a very common 5-question screening tool that suggests that an eating disorder might exist. And then there are 2 extra questions you can use to increase specificity for bulimia. Another questionnaire that you can use is the eating attitudes test. And Kate and I are going to put together a little packet that has a lot of different resources in it, including the eating attitudes test and the compulsive exercise test. There are some other tests listed here. And you could also go to the National Eating Disorders Association website or the ANAD website, where you would find another screening tool that you could actually do with a client or a patient in your office. So once you decide that someone has an eating disorder, it's helpful to understand that there are a lot of different levels of care for treatment, starting with the outpatient level of care, which is obviously the one that we would all be involved in, which consists of developing a team that ideally includes a therapist, a primary care physician, a nutritionist, and perhaps someone who's going to prescribe psych medications, either a nurse practitioner or a psychiatrist. For people who need a higher level of care, the next level is the intensive outpatient. The problem is that there aren't any treatment programs locally. The closest IOPs and partial hospitalization programs that I know of are in Concord, New Hampshire at the Cambridge Eating Disorder Center. My understanding is that the Adams Center in Burlington has closed, I think. There is a place in Burlington called the CALM Clinic where they do some metabolic training, testing, and they also have an eating disorder specialist on staff, so that would be a possibility. Parker Ray is a psychologist in Montpelier who is going to be teaming up with Laura Byron, a dietitian in Stowe, to offer some supervision groups for counselors and therapists who are interested in getting more support for treatment. For caring for people with eating issues. The next level of care is residential treatment. Again, nothing in Vermont, but tons of places all over the country and many in the Boston area. And then inpatient hospitalization is for people who are not stable enough medically to go to residential treatment. The American Psychiatric Association has established actual guidelines for which level of care somebody would fall into, and it's based on their labs and their heart rate and their weight, their motivation for recovery, their ability to follow a meal plan that's been developed for them. their ability to resist purging activities, their suicidality, and their ability to travel to and from treatment. But when a higher level of care is needed, it's often actually decided by the treatment facility. So a family and their treatment team, outpatient treatment team, might call a higher level of care facility, and they would do an intake evaluation, and then they would say what level of care they think is appropriate. So it's really a good idea to not, like if you're working with an adolescent and their parents, they might think, oh, it would be great if we could do an intensive outpatient because we don't have time to go to residential residential treatment because it would take up too much time. So then when they do their intake evaluation, the facility might say, you need residential. So it's just good to not get anyone's hopes up about what they might be headed for. So who is appropriate for an outpatient level of care? And I sort of say this with, not reservations, but in my experience, a lot of people who would benefit from a higher level of care are managed in an outpatient setting for a lot of reasons. Maybe because their insurance doesn't cover it, maybe because the parents and or the individual is resistant to going to a higher level of care, or maybe because their insurance won't pay for it. But in generally, they should be pretty medically stable and not require a lot of monitoring by their primary care physician. So what does a lot mean? I would say monthly would be appropriate in an outpatient level of care. And they should be able to follow some general plans and resist urges to engage in eating disorders behaviors that are really damaging for them. So as I said before, the optimal care really includes having a multidisciplinary team, and it's really helpful to have someone on the team who is knowledgeable about eating disorders. And I added the family to this because in my experience, behind every person who's gotten better, not every person, that's not fair, but eating disorders are so hard, and they're it's like having this bad relationship in your head that's telling you to do things that are really destructive. So having parents and or partners or spouses who can support you in overcoming those behaviors is really, really helpful. So the treatment is going to really revolve around some kind of counseling along with nutritional care and medical management. The Academy for Eating Disorders has this fabulous little booklet that was last updated in 2016, which I'm going to put in the packet for you. But it has everything that you need to know about managing folks who have eating disorders. But in a nutshell, there are certain labs that should be done, as well as an ECG. And then weights are always tricky because it can be really, really triggering for someone with an eating disorder to see their weight, but yet we have these electronic medical records that people can log into, and we sometimes send home visit summaries that have weights and BMIs on the bottom of them. I'm not quite sure how to address that, but it's really important to know what someone's weight is, and it's important for the team to know what the weight is, but how do we do that without harming if our goal is to help people get better? Growth charts, again, are just absolutely a gold mine of information, as well as helpful for getting an idea of where someone's weight should be going as they're recovering from their eating disorder. People can be orthostatic who have eating disorders, so checking their heart rate and blood pressure both when they're lying down and when they're standing is valuable. And it's really helpful and important to be aware of tricks that someone might use to manipulate their weight, like running around in the parking lot before they come in to increase their heart rate, or drinking tons and tons of water, or putting coin rolls in their pockets, or taping things inside their underwear. The list goes on and on and on. So other things that medical providers can do, I'm going to skip that because I'm watching the time go along here quickly. Nurses, I think, have a really important role with identifying things that might be clues. For example, if someone comes in with lots and lots of clothes on and it's a warm day, maybe they're hypothermic, or maybe they're trying to cover up what their body looks like, but being aware of that, and also being a role model for weight and body image and attitudes about those things. I know the behavioral health folks are really anxious to get some information, so I'm going to skip ahead. But the first goal is to reduce the eating disorder behaviors, and at the same time as you're developing a therapeutic relationship. There are a lot of different modalities used, especially DBT and CBT. I wanted to mention also in particular family-based treatment, which is a manualized approach which is especially effective for adolescents who have eating disorders. And in this approach, the family is basically absolved of blame. You know, we want to get parents don't cause eating disorders, and we want to get everyone on deck to help get this young person back to eating and not over exercising. So the parents are empowered to take the reins with their young person's eating, and the therapist teaches them how to do that. So it has some of the best efficacy available in eating disorders treatment. So there are a lot of different things that therapists can do to help people recover from eating disorders. I've gone through my stash of books, and I'm going to donate a bunch of them to behavioral health. But Carolyn Costin is a therapist who's opened several eating disorder programs throughout the country, and she's also written some wonderful books, 8 Keys to Overcoming an Eating Disorder, as well as a workbook that goes along with it. And one of the things that she finds particularly helpful is helping the person with an eating disorder separate their eating disorder self and their healthy self. And the therapist really aligns with the healthy self and helps the person move away from their eating disorder behaviors. And so it's fairly easy to do that, because you can say to the client, well, if you were babysitting a 7-year-old and they said they were going to throw up their pizza, like, would you be okay with that? And no, of course not. And that's sort of the eating disorder self telling the person that they should throw up their pizza. Some other things that therapists can do is be aware of body checking and help patients or clients become aware that they're body checking, and maybe do some journaling about that and notice when it's increasing or decreasing, and learn about the triggers, the emotions, the situations that lead to that. You can eat with clients and do food exposures with them. That can always be fun and interesting. Teaching clients that fat is not a feeling. Oftentimes, clients say that they feel fat, but just as you can't feel that your eyes are blue or that your hair is brown, you can't feel fat. So feeling fat is really it's a sign, it's a code for something else that's up, and helping patients understand that, because if they feel fat, that's going to make them want to restrict their eating or exercise more or purge, even though their body shape and size has not changed at all during that day. So that can be a very valuable thing to do. And then never ever giving up hope. You can also teach parents what you do to help their family member get better. So these are some of the books that I think might be helpful. I have the cognitive behavioral therapy and the 8 keys, both of which I can give to behavioral health. I can't find the manual for anorexia nervosa, but that's the family-based treatment book. I want to talk a minute about figuring out how much someone should weigh, and not making the mistake of saying, well, you're at the 50th percentile, so that's good. Because if you were always at the 90th percentile, you should return to the 90th percentile. And that's really hard for people to get their head around. But if someone has to exercise a lot and restrict their eating to stay at the 50th percentile, it's too thin, and they're going to have to continue with their eating disorder. So they're really looking for like a state, not a weight. Are they getting their period? Are they agreeable and sociable? How are their vital signs? So that's another great reason to have that orthostatic data for blood pressure and heart rate, because you can look back and say, well, when you were not eating, your blood pressure and your heart rate were really low, but look how much better they are when you're in a better state. So here's a young lady's growth charts. She was going along nicely, and then you can see where she developed her eating disorder. And so we really had to get her back up to the 75th percentile, and she was really resisting getting all the way up there. But 4 pounds made a huge difference in the therapist could see such a difference in someone with a better nourished brain that's been marinated in all that nice nutrition. So that made a huge difference. So when you're concerned about a child's growth, be curious, and as Kate said, focus on the same healthy lifestyle recommendations you would with any family. Whether the child is fat or thin, they all need exercise, they all need to eat well, they all need to have regular meals and love and all of that stuff. Some of the leaders in the field for for advice and consultation are Katya Rowell, Kathy Caters, a therapist who was behind all those little signs that we've put up around the scales. And Ellen Satter is an amazing dietitian and therapist from Wisconsin. Okay. I understand. This is the last slide. Okay. Okay. If you need to leave, please head out, because I understand that it's the end. Okay. Okay. Yes, definitely. Okay. So for those of you who are still here and want help staying on the cutting edge, if you're a therapist, supervision and consultation are the most powerful way that I know of to review cases and to get support and to just work with these wonderful, interesting, challenging individuals. For continuing education, the International Association of Eating Disorders Professionals has a multi-day symposium every February, March, which is online. Also, the Renfrew Foundation has their conference coming up. It's going to be open from November 11th to December 31st. And the META is the Multi-Service Eating Disorder Association in Massachusetts that has a multi-day presentation. There's a physician from Denver, Colorado, who does case consultation and supervision, has written a book called Sick Enough. I already mentioned Carolyn Costin. Janine Anderson is a psychologist with some podcasts. And then there's a couple of resources that are great for parents at the bottom. So really wonderful group of people to work with. These folks, when they get better, the things that make them sick are are sometimes their attention to detail, their perfectionism, a bunch of traits, but when those things are overcome, they can really soar, S-O-A-R, in their lives and become just, wonderful individuals. They're wonderful anyway, but they can really be great. So that brings us to the end of our presentation, and Kate and I are available for consultation, and we're looking forward to a Q&A session in late October to further our discussion about these topics.
Wonderful. Thank you both, Kate and Hillary. Thank you all for attending. We will send out the slides and the recording so folks can refer back to it.
Wonderful. Thank you.
Thanks all. Have a good day.